Good morning, everyone. I'm Dr. Hia Boru. I'm a practicing endocrinologist at Sharjah, UAE. Continuing with her MRCP classes, I'm here again with the video on infectious disease. Today, we'll be covering a few very important topics on infectious disease part for MRCP Part 1 and Part 2 exams. So, without delay, let's start. We already covered 5 questions in the first video. So, this will be question number 6. The question says that a 52-year-old male presents with a 48-hour history of productive cough. He is employed as a dairy farmer. On examination, a cold sore is observed on his lower lip. His vital signs are as follows. He has a heart rate of 105 beats per minute. Blood pressure is 125 by 75 millimeter of mercury. Temperature is 38.2 degrees Celsius. Respiratory rate is 18 breaths per minute and oxygen saturation is 95% on room air. His laboratory findings are as follows. Hemoglobin is 12.5 gram per deciliter. Platelets are 1,54,000. He has evidence of infection in his blood with a total WBC count of 23.1 thousand, which is quite high. His electrolytes are normal. However, his C-reactive protein, that is CRP, is elevated, 321 milligram per liter, again suggestive of infection. Now he undergoes a chest X-ray. The chest X-ray shows left-sided lobar pneumonia. So the question is asking which organism is most likely implicated in this infection? The options are Chlamydia psittaci, Coxiella burnetii, Mycoplasma pneumoniae, Staphylococcus aureus, or Streptococcus pneumoniae. Now think about this patient's clinical condition and his lab findings and imaging findings and try to guess which organism is likely implicated in this clinical presentation. Yes, the answer is E, that is Streptococcus pneumoniae. Now, let us understand what is Streptococcus pneumoniae and what diseases Streptococcus pneumoniae causes. Streptococcus pneumoniae is a gram-positive encapsulated bacterium. It is commonly associated with various types of respiratory infections. It is the most common cause of community-acquired pneumonia, which is the most common type of pneumonia, particularly in adults. In addition to causing CAP, Streptococcus pneumoniae is also responsible for causing otitis media, sinusitis, meningitis, and sepsis. Now, coming to the pathophysiology, Streptococcus pneumoniae is usually spread through respiratory droplets. There is nasopharyngeal colonization, which can lead to lower respiratory tract infection. The virulence factors promoting Streptococcus pneumoniae infection are the capsule of the Streptococcus pneumoniae, which protects against phagocytosis by the macrophages. Then there is another agent which is known as the pneumolysine. The pneumolysine that is produced by Streptococcus pneumoniae damages the respiratory epithelium and impairs the immune response. And it also produces certain agents known as autolysins, which contribute to tissue destruction and inflammation. Certain hosts are particularly susceptible for Streptococcus pneumoniae infections, particularly those with underlying lung diseases such as COPD or history of smoking, or those with weakened immune systems such as patients living with diabetes. Now, what is the clinical presentation of pneumococcal pneumonia? The pneumonia that is caused by Streptococcus pneumoniae is also known as pneumococcal pneumonia. The common symptoms are productive cough. Often the color of the sputum is rust colored. There may be accompanying fever and chills, pleuritic chest pain, dyspnea, that is shortness of breath, and one very, very important clue in this question was herpes labialis, that is cold sores. So streptococcus pneumoniae or pneumococcal pneumonia can usually follow infection by herpes labialis, which can result in cold sores. In pneumococcal pneumonia, the physical examination findings can be tachypnea, which is elevated respiratory rate, tachycardia, which is elevated heart rate, as was present in our case. There may be dullness to percussion over the affected lung. So the part of the lung which is consolidated, if you percuss, it will be dull on examination. And on auscultation, you may get to hear crackles or rails on that part of the lung which is consolidated. Now, in this case, what were the key findings that helped us in identifying the causative agent as Streptococcus pneumoniae? The patient had productive cough with fever and elevated inflammatory markers like WBC and CRP. The chest X-ray was suggestive of lobar consolidation, which is very, very typical for pneumococcal pneumonia. There were certain risk factors in this patient, like his occupational exposure. He was a dairy farmer and he had increased exposure to environmental pathogens. But one thing is important, that pneumococcal pneumonia can occur in adults with patients who are not even exposed to environmental pathogens. They can also be suffering from pneumococcal pneumonia. Cold sore or herpes simplex virus. So this indicates a possible viral reactivation, which could predispose the patient to secondary bacterial infections like pneumococcal pneumonia. So in the question, if it is mentioned that the patient has a herpes simplex virus infection or cold sore, the pneumonia that usually follows is pneumococcal pneumonia. So these are the chest X-ray findings in lobar pneumonia. So as you can see here the right lobe is involved, the lower lobe is involved. So this typical lobar pneumonia is classically seen in Streptococcus pneumoniae infection. Now, what can be the complications of Streptococcus pneumoniae infection? There may be some pulmonary complications and some systemic complications. Pulmonary complications like fluid accumulation in the pleural space leading to parapneumonic effusion, empyema when the fluid gets infected, in the pleural fluid gets infected, and empyema is an indication for putting a chest tube. And lung abscess can also occur. The lung abscess means necrosis of the lung tissue. And certain systemic complications can also occur following pneumococcal infection, like bacteremia, which is spread of infection into the bloodstream. Sepsis is a life-threatening organ dysfunction leading to multi-organ failure caused by Streptococcus pneumoniae, and meningitis involving extension of the infection into the central nervous system. Now, what are the treatment guidelines for pneumococcal pneumonia? The first line antibiotics are penicillin or amoxicillin if there is no resistance. However, this penicillin amoxicillin resistance is very, very common nowadays. So, in milder cases, we can use macrolides like azithromycin. In the moderate to severe cases, we can use a higher spectrum of antibiotics like the third generation cephalosporins, such as ceftriaxone or cefotaxime. And for penicillin resistant cases, we can use fluoroquinolones like levofloxacin. Supportive therapy is also very important, like oxygen supplementation when the SpO2 was 95% in this case. So this person requires oxygen supplementation, antipyretics for fever, and hydration and rest. Now, how can we prevent pneumococcal pneumonia? So for this, vaccination is very, very important. There are two vaccines for pneumococcal pneumonia. One is the pneumococcal conjugate vaccine, which is PCV13. This is usually administered in children or adults with comorbidities. And another is a pneumococcal polysaccharide vaccine, which is a PPSV23 for older adults and high-risk groups. Hygiene measures are also very important, hand washing and use of masks to prevent respiratory droplet transmission, and avoiding close contact with individuals who are suffering from active infections. So, all these are protective measures to protect oneself against pneumococcal pneumonia. Now, what about the other options which were mentioned in the question? Why is it not Coxiella burnetii? So, Coxiella burnetii is the causative agent of Q fever. Q fever is a zoonotic disease. Q fever primarily affects animals like goats, sheep, and cattle, and humans typically contract the infection through inhalation of contaminated particles from animal products like bird fluids, wool, or milk. Now, the epidemiology of Q fever suggests that certain occupations are at higher risk for contracting Q fever, particularly farmers, veterinarians, and people walking with livestock. They are at higher risk for contracting Q fever. The bacterium, that is Coxiella burnetii, is resilient and can survive in the environment for a very long period. Coxiella burnetii, again, like other respiratory pathogens, it is also commonly transmitted via inhalation of dust contaminated with animal secretions. Rarely, it can be transmitted through ingestion of unpasteurized milk. Now, what are the clinical manifestations of Q fever? Q fever may be of two types: acute Q fever and chronic Q fever. Acute Q fever usually presents with a flu like illness such as fever, headache, and myalgia. It can also lead to development of atypical pneumonia. It causes more of interstitial or patchy pneumonia rather than lobar pneumonia. So in this question, the chest X-ray was mentioning typical lobar pneumonia, which is unlikely in case of Q fever. Q fever causes more of interstitial or patchy pneumonia rather than the lobar pneumonia. Chronic Q fever is rare, but it can lead to serious complications like endocarditis or hepatitis. So why Coxiella burnetii is unlikely in this case? So this patient was a 52-year-old dairy farmer. So although he has some occupational risk, but he presented with productive cough, fever, and lobar pneumonia, which was seen on the chest X-ray. So typical Q fever usually presents with interstitial pneumonia or flu-like symptoms, unlike what is mentioned in this question. Lobar pneumonia is very uncommon with Q fever, making it an unlikely diagnosis. So presence of lobar pneumonia is more consistent with Streptococcus pneumoniae infection rather than Coxiella burnetii. Now, what is a treatment for Q fever? The first line treatment for Q fever is doxycycline, which is the antibiotic of choice. Doxycycline dosage is 100 milligram twice daily for 14 days. Start treatment as early as possible for the best outcome. And treatment of chronic Q fever, generally we give a combination therapy of doxycycline 100 milligram twice daily and hydroxychloroquine 200 milligram three times daily. And duration is very prolonged, usually around 18 months to 3 years of treatment is required, especially in cases involving endocarditis. Now, the third option was Mycoplasma pneumoniae. So, why is it again not Mycoplasma pneumoniae? So, Mycoplasma pneumoniae again causes atypical pneumonia, particularly in younger populations. Mycoplasma pneumoniae lacks a cell wall, making it resistant to beta-lactam antibiotics. Mycoplasma pneumoniae again spreads through respiratory droplets, often in crowded settings like boarding schools or military barracks. The clinical features of Mycoplasma pneumoniae infection, it causes flu-like illness like low-grade fever, sore throat, dry cough, and malaise. Again, it presents as atypical pneumonia rather than a lobar pneumonia. The pneumonia is more of patchy or interstitial infiltrate rather than the lobar consolidation. Mycoplasma pneumonia usually has a gradual onset with prolonged cough, sometimes lasting weeks. Now, what are the lab findings in Mycoplasma pneumoniae infection? The typical finding of Mycoplasma pneumoniae infection is a red cell agglutination, which is a hallmark feature in some cases. It can also cause cold agglutinin disease. Now, this is very, very important. If cold agglutinin disease is mentioned, then remember that the agent is Mycoplasma pneumoniae. So, this cold agglutinin disease can lead to hemolytic anemia in rare cases. The diagnostic test for Mycoplasma pneumoniae is again serology or PCR. The chest X-ray typically shows diffuse patchy infiltrates but not lobar consolidation. The treatment of Mycoplasma pneumoniae, the first line treatment is macrolide, that is azithromycin 500 milligram on day 1, followed by 250 milligram per day for 4 days. Other than azithromycin, we can also use clarithromycin 250 to 500 milligram twice daily for 7 to 14 days. Macrolides are preferred in children and pregnant women due to safety and effectiveness. The other alternative antibiotic therapy for Mycoplasma pneumoniae infection are tetracyclines, that is doxycycline 100 milligram twice daily for 7 to 14 days. However, remember that doxycycline is contraindicated in children under 8 years of age or pregnant women. Other antibiotics that we can use is fluoroquinolone, levofloxacin 500 to 750 milligram daily for 7 to 14 days, moxifloxacin 400 milligram daily for 7 to 14 days. Fluoroquinolones are effective in adults but should be used cautiously due to potential side effects. Adjunctive treatment for mycoplasma, again same like supportive care such as hydration and rest, antipyretics for fever and myalgia. Cough suppressants should be used if the cough is severe, though mild cough is generally beneficial for clearing the secretions. Now the last option was Staphylococcus aureus. So why it is not a staphylococcal pneumonia? In Staphylococcus aureus infection, the primary pneumonia is rare, but still it can occur, especially in individuals who have a weak immune system. Secondary bacterial pneumonia by Staphylococcus aureus is more common, and it usually follows viral infections like influenza A. So, the staphylococcal pneumonia is usually seen in patients who experience bacterial superinfection after the influenza. The clinical features of staph pneumonia, it can produce cough with purulent sputum, high-grade fever, and dyspnea. The most important thing is that staph pneumonia can lead to lung cavitation or abscess formation, particularly in severe cases. It can also lead to serious complications like empyema, which means pus or infected fluid in the pleural space, sepsis, and abscess. It can be a more aggressive form of pneumonia compared to other bacterial causes. So, staph pneumonia is actually the most aggressive form of pneumonia because it usually leads to lung abscess or empyema, sepsis, and overall bacteremia. Staph pneumonia is usually associated with influenza, so there is a well known secondary bacterial infection after the flu. It can lead to severe pneumonia and rapid deterioration. A hallmark of staph pneumonia is lung cavitation, which is very important feature of staph pneumonia. So this is the chest X-ray typical imaging of staph pneumonia. This marker it represents lung cavitation, which is seen after in a patient who is infected with staph pneumonia. Now, coming to something which is known as community acquired pneumonia. So, community acquired pneumonia means infection of the lung parenchyma in patients not recently hospitalized or in long term care. So, basically, community acquired pneumonia means infection of the lung or consolidation of the lung in those patients who have not been hospitalized. There are various types of pneumonia like hospital associated pneumonia, ventilation associated pneumonia. The most common type of pneumonia is the community acquired pneumonia, which occurs in those individuals who have not been recently hospitalized. This community acquired pneumonia is the leading cause of infectious disease related deaths worldwide. Now, the common infectious agents in CAP, as I already told you, Streptococcus pneumoniae, which accounts for 80% of the cases. Other agents that can cause CAP are Haemophilus influenzae, Haemophilus influenzae. CAP is, however, more common in smokers. Staph pneumonia again follows influenza infection. Other atypical organisms can be Mycoplasma pneumoniae, Legionella, and Chlamydophila. The less common infectious agents of CAP are viruses, including influenza and respiratory syncytial virus, and Klebsiella pneumoniae. Klebsiella pneumoniae, however, is more common in alcoholics and patients with chronic diseases. Okay, so that was all about pneumonia. I hope you have understood what is the various spectrum of presentation of pneumonia, particularly in the pneumonia that is caused by Streptococcus pneumoniae, Coxiella burnetii, Mycoplasma pneumoniae, and of course staphylococcal pneumonia. So this pneumonia question is very important, and you need to go through each and every spectrum of the disease. So the next question is, so this is a 72-year-old woman who underwent a total hip replacement after sustaining a fractured neck of the femur due to a fall. On the sixth day post-surgery, she developed a noticeable infection at the surgical site. A swab of the discharge revealed the presence of a gram-positive coccus, which is resistant to multiple drugs, including beta-lactam antibiotics. So, what is the most appropriate antibiotic for her treatment? A. Ceftriaxone, B. Ciprofloxacin, C. Couamoxiclav, D. Teicoplanin, E. Clindamycin. So you just read the question. This is a old woman who underwent a hip replacement, and after the sixth day of her surgery, she sustained an infection. And on the culture, it has been found that there is the growth of an organism which is gram positive and is resistant to many antibiotics, including beta lactam. So think which organism this question is referring to, and after you identify the organism, you should find out which is the most appropriate antibiotic for the treatment of this organism. Try to guess. Yes, the answer is D, that is teicoplanin. Now, this question actually refers to the presence of MRSA. MRSA means methicillin-resistant staph aureus. Methicillin-resistant staph aureus or MRSA is becoming very common nowadays because of widespread and inadvertent use of antibiotics across various hospitals. So this MRSA has been it's a very common organism which we find nowadays. So MRSA is a strain of staph aureus. It is resistant to methicillin and other beta-lactam antibiotics. This resistance is mediated by the MAC-A gene, which encodes for an altered penicillin binding protein. This is how MRSA looks like on electron microscopy. So there are clusters of gram-positive foci, and they are resistant to all antibiotics, including beta-lactams. They appear somewhat greenish in color on electron microscopy. You may get this picture, particularly in MRCP Part 2 exams, where images are displayed on the examination paper. So, what are the antibiotics which promote MRSA acquisition? The antibiotics that commonly promote are ciprofloxacin, which belongs to the class of fluoroquinolone. It exerts selective pressure on susceptible bacteria, leading to MRSA emergence. Secondly, the cephalosporins. So, we have seen that there is widespread and inadvertent use of cephalosporins, including ceftriaxone and cefotaxime. The cephalosporins belong to beta-lactam antibiotics. The widespread use has been linked to development of MRSA and other resistant organisms. Clindamycin, which belongs to the lincosamide class, clindamycin, when used inappropriately, can also contribute to resistance if used alone in some MRSA strains. Now, who should be screened for MRSA infections? All patients awaiting elective admission should be screened for MRSA infections. Exceptions are only day patients who are having terminations of pregnancy and who are undergoing ophthalmic surgery. Or these patients are exceptions. Otherwise, every patient who is awaiting elective admission should undergo MRSA screening. And patients admitted to mental health trust, they are also excluded from MRSA screening. From 2011 onwards, the guidelines mentioned that all emergency admissions should also be screened for MRSA infections. Now, how should a patient be screened for MRSA infection? The screening method is a collection of a nasal swab that is wiped around the inside rim of the nose for 5 seconds. Then we can also screen the skin lesions or wounds, and the microbiology formed should be specially labeled as MRSA screening. Now, how can we suppress MRSA in carriers? So, if in the screening we find that the patient is a MRSA carrier, then we can use a certain agents for MRSA suppression. For nasal suppression, we can use mupirocin 2% in white soft paraffin 3 times daily for 5 days. So, this is very, very important. For nasal suppression, use mupirocin ointment 2% in white soft paraffin for 5 days. For skin suppression, you can use chlorhexidine gluconate once daily for 5 days. Apply all over, especially to the axilla, groin, and perineum. So these are the areas which are particular carriers for MRSA. So you need to apply everywhere, but particularly to the areas with axilla, groin, and perineum. Now, what are the antibiotics for the treatment of MRSA infections? The first line treatment includes antibiotics such as vancomycin, teicoplanin, and linezolid. So remember, vancomycin, teicoplanin, and linezolid. So teicoplanin is the correct answer in this question. The additional antibiotics, which should not be used as monotherapy but in combination with the first line agents, are rifampicin, macrolides, tetracyclines, aminoglycosides, and clindamycin. So remember, this should not be used as monotherapy for the treatment of MRSA infections. They should always be combined with the first line agents. The newer antibiotics for resistant MRSA cases that we can use nowadays are linezolid, which is a very, very good antibiotic for resistant MRSA cases. We can also use quinipristine and delfopristine combinations. And another agent which is also very good for MRSA resistant cases is tigecycline. So these are some of the antibiotics: vancomycin, linezolid, and teicoplanin. In addition, quinipristine and tigecycline. Okay, that was all about MRSA. Then, sorry, this is question number 8. This question number 8 is so this patient, his name is Robin. He's a 24-year-old male. He presents with general malaise and fever. He reports feeling fatigued for the past 4 weeks with associated bilateral knee aches that have not improved with rest. 4 weeks prior to presentation, he experienced fever and chills. Robin mentions spending a week hiking in the Scottish Highlands last month, during which he noticed a possible insect bite. However, no rash developed, and he denies other systemic symptoms, including cough, dysuria, or urinary frequency. Based on this history, what is the most appropriate next step? Administer IV ceftriaxone, discharge with advice to monitor appearance of rash or worsening of clinical symptoms, ELISA antibody test and start doxycycline while awaiting the results, immunoblot test, or administer doxycycline and follow up in 2 weeks. So just try to read up the question. So this is a patient. He has history of fever, and he gives history that he went for a hike in the Scottish Highlands, and there was an insect bite. However, there is no appearance of rash, and now he presents with mild degree of fever and arthralgia. As you can see, there is bilateral knee aches which have not yet improved with rest. And before that, he experienced fever and chills, and he denies any systemic symptoms. So, what will you do in this patient? So, these are the 5 options. Yes, the answer is ELISA antibody test and start doxycycline while awaiting the results. So I believe you have now guessed what disease this question is referring to. So the clues in the question are: he's a 24-year-old male. He presents with certain non-specific symptoms like generalized malaise, fatigue, and fever. There is 4 weeks of fatigue and bilateral knee ache, fever and chills 2 weeks ago. Another important history was that he recently hiked in the Scottish Highlands and noted an insect bite. However, there was no rash, and he does not have any systemic symptoms like cough, dysuria, or urinary frequency. So the question here definitely refers to Lyme disease. Lyme disease because there are certain non-specific symptoms like fatigue, joint pain, combined with a very important history of hiking, particularly in the Scottish Highlands, and there is a history of insect bite as well. And there is lack of systemic features like dysuria or cough or chest pain. So this suggests less likelihood of other common infections. Now, the rash, which is typically found in Lyme disease, is known as erythema migrans. So, although this patient did not have rash, but this rash, that is erythema migrans, is typically diagnostic for Lyme disease. The presence of rash allows for immediate diagnosis and treatment with doxycycline. This patient does not have a rash, so for this patient, further testing is required before initiating treatment. So the last option where it was mentioned that start the patient directly with antibiotic is not correct because this patient does not have a rash. So in this patient, further testing is required before starting the antibiotic. Now, the first line test in a suspicious case of Lyme disease is ELISA antibody testing. ELISA antibody testing is the preferred initial test when the rash is absent but Lyme disease is suspected. After ELISA is positive, we have to do a confirmatory test, which is an immunoblotting test or Western blot test. In high clinical suspicion, you can consider starting oral doxycycline even while awaiting the test results, especially if other causes are ruled out. So in this patient, he was a case of high clinical suspicion of Lyme disease. So in this patient, while the test results are awaited, you can already start doxycycline in this patient. Now let us come to know about the details about Lyme disease. Lyme disease is caused by the spirochete Borrelia burgdorferi and it is spread by ticks. So tick bites are responsible for causing Lyme disease and it is caused by spirochete which is known as Borrelia burgdorferi. The early features before 30 days, it includes erythema migrans, which is a typical rash in Lyme disease. Bullseye rash is typically seen at the site of the tick bite. The rash typically develops 1 to 4 weeks after the initial bite, but it may present sooner, and it is usually a painless rash. It is more than 5 centimeter in diameter and it slowly increases in size. It presents in around 80% of the patients. However, in our patient, the rash was absent. So this is how an erythema migrans rash or Lyme disease rash looks like. This is a typical bullseye rash. As you can see, this is a maculopapular rash and forming concentric circles. This is another rash at the site of the tick bite, which is known as, you can see some reddish discoloration here. So all these are typical examples of the Lyme disease rash. The systemic features of Lyme disease can be headache, lethargy, fever, and arthralgia. The later features, which usually appear after 30 days, are it can involve the cardiovascular and the neurological system. In the cardiovascular system, it can lead to heart block or peri or myocarditis. In the neurological system, it can lead to facial nerve palsy, radicular pain, and meningitis. Now, what are the investigations of Lyme disease? As already mentioned, the NICE guidelines recommend that Lyme disease can be diagnosed clinically if erythema migrans is present. Erythema migrans is an indication to start antibiotics immediately. The first line diagnostic test if erythema migrans is absent is ELISA. So this is the first line test for detecting antibodies against Borrelia burgdorferi. This ELISA test is performed when no rash, that is erythema migrans, is if rash is absent and but Lyme disease is clinically suspected. Now, what is the follow-up testing? If ELISA is negative but symptoms persist for less than 4 weeks, repeat ELISA in 4 to 6 weeks. If the symptoms last 12 weeks or more, then perform directly an immunoblot test. So this is again important. See, if ELISA is negative but symptoms are persisting for less than 4 weeks, if it is less than 4 weeks, repeat ELISA in 4 to 6 weeks. But if the symptoms have already crossed 12 weeks, then you should directly go ahead with an immunoblotting test. If ELISA is positive or equivocal, directly proceed with an immunoblot test for further confirmation of Lyme disease. Now, how do you manage tick bites? For management of asymptomatic tick bites, tick bites are relatively frequent in general practice, but it can cause significant anxiety among patients. Now, there's a tick removal technique. If the tick is still present, you have to use fine tip tweezers. Grasp the tick as close to the skin as possible, pull upward firmly without twisting, and wash the area with soap and water after removal. So this is very, very important. So this is the tweezer. You have to use a very fine tip tweezer and pull the tick upward. And after pulling the tick upward, after you remove it, then clean the area with soap and water. Now, antibiotic use after tick bites. Do we recommend routine antibiotic treatment after tick bite? The answer is no. Routine antibiotic treatment is not recommended for patients with a tick bite unless there are suspicious symptoms of Lyme disease. So this is very, very important. You may get a question like this. So the patient he's suffered a tick bite. So do we recommend routine antibiotic treatment after tick bite? The answer is absolutely no. Only when there are symptoms suspicious of Lyme disease, we recommend antibiotic treatment. Otherwise, for general asymptomatic tick bites, we do not recommend antibiotic usage. The management of Lyme disease, the first line treatment is doxycycline. If doxycycline is contraindicated, for example, in pregnancy or in children, amoxicillin is an alternative. Erythema migrans, as I already mentioned, erythema migrans is a clear-cut indication to start antibiotic immediately, even without waiting for a diagnostic test. So if erythema migrans or a typical rash is displayed in the picture, particularly in MRCP Part 2 exams, you have to start the antibiotics immediately without even waiting for the diagnostic tests. For disseminated Lyme disease, you should use ceftriaxone, particularly in patients who are having neurological or cardiac involvement. Remember the Jarisch-Hersheimer reaction. So this is a reaction which can occur after the first dose of antibiotics. So this reaction is typically seen in syphilis. However, it can also be seen in cases of Lyme disease. It is usually caused by, certain antibiotics, particularly penicillin and beta-lactams like ceftriaxone. So Hersheimer reaction can occur even in Lyme disease patients. So that was all. We discussed three questions today. We discussed pneumonia, we discussed MRSA, and we discussed Lyme disease. I hope you are now very clear with all the three topics. We'll come with the next video on infectious disease very soon. Thank you very much and keep preparing for MRCP Part 1 and Part 2 exams. All the best.